in patients on heart that are treated for years by heart. We have to understand better those complications for taking care of these non-AIDS associated morbidity and have new strategy for tomorrow. And I'm concerned, and you in those countries, you have to be concerned, because at one point you may have the two profiles at the same time, the AIDS-associated morbidity and the non-AIDS associated morbidity as well. So you have to anticipate already those two issues. And we have to progress, because of course we all dream of a world without HIV. We all dream about eradication of HIV. As an old retrovirologist working on this family of viruses, I must say, and I'm not pessimistic usually, but I must say that I don't really believe that we will be able one day to totally eradicate HIV from the body. But I am convinced that we shall be able at least to have what we call the functional cure of AIDS. That means to reduce the size of the reservoir for the virus in different compartments of the body. So for that we need, again, like always, to mobilize everybody to work and to make new research programs, to elaborate new molecules, to have new targets for therapy, and to find a solution for the functional cure of AIDS. There are progress already. There are progress already regarding the potential strategy to target those viral reservoirs. Some of them are not be very efficient. Like, for example, there is data trying to intensify the treatment in the patient to reduce the size of the reservoir in the body. The first data have not been so promising. There is new approaches and studies going on by very intense antiretroviral therapy very early on to try to decrease the size of the reservoir in the body. We will see the data. We have new drugs already that can improve the penetration and the potency of the drug within the target cells. We already tried to associate antiretroviral treatment with immunomodulators to activate the cells where the virus is dormant, latent, and thus to reduce the size of reservoir, because on antiretroviral treatment, then if the virus is expressed, it cannot spread into other cells. This has not been so successful up to now. But there is new approaches that are coming, new approaches that are already coming that aim to unlock the latency of the virus within the target cells. We are understanding better and better the mechanism of latency, and there is drug and development. Of course, still it's at the level of basic research, but some of the drugs are research for within the next year. So we have promising strategy for the future. Regarding the prevention strategy, of course, you know that microbicide has been quite deceptive with failures to try to prevent the sexual transmission of HIV-1, the classical microbicide approach. But there are new approaches using specific, what we call specific microbicide. Indeed, that's antiretroviral treatment used as microbicide. and it's what we call the specific one. The first data, some of them were promising, some of them are more deceptive, but this is an approach that should continue. Regarding another approach is circumcision. Circumcision not alone, of course, but we know that circumcision can reduce the risk of infection, sexual transmission by 50–60%. This is one approach to consider associated to others. And the first thing that I have on my slide, the first line, is the use of antiretroviral treatment, not only as treatment, but as prevention. As prevention, pre or post-exposition prophylaxis, but also as early treatment. The test and treat concept. Test and treat concept. Test as early as possible to know if you are HIV positive. If you are HIV positive, you can be treated. This is a wonderful thing because in the past, we could not propose the treatment early. And we know today that if the treatment is proposed early, there is a benefit at the individual level and there is a benefit at collective level. Because we know, and there is already data indicating that if a partner is treated and is on heart, there is a reduction of the risk of transmission to his partner by more than 90%. So the treatment itself is part today of preventive measure. Of course, there is a problem of feasibility, particularly in the developing world. But we really have to think about it for the future. And of course, on that slide, I'm mentioning vaccine, and I will say a few words on vaccine, which has been a failure up to now until the modest data of the trial that was available at the end of last year. The test and treat concept. We know that antiretroviral treatments stop viral replication, and as a consequence, there is undetectable viral load in the blood and most of the time in the genital secretion. It was a model published in Lancet at the end of 2008, showing, according to this mathematical model, that we have indeed the chance to stop the AIDS of the epidemic if we were able to universally, voluntarily test for HIV and treat immediately by heart the HIV positive individual. You can see that according to this model, if we were able to use this test and treat concept globally, the epidemic can stop in 2020. Of course, it will be almost impossible to reach this aim, but this is certainly an important thing to consider. What will be the prevention in the future? The prevention in the future to reduce the incidence of HIV-1 will be certainly a global response combining treatment and prevention together. The combination will include different components and, of course, education. Education is one important component for prevention. Education for behavioral changes of the population, of the civil societies, of some communities. Of course, we have to combine two biomedical strategies that has been proven to be efficient, like the usage of condom. Circumcision might be considered as part of it. We have also, as I just mentioned, the components now of treatment, antiretroviral treatment as part of the prevention. And there is a last component, which is really important. social justice and human rights. This is a critical issue. The reason why today it's very difficult to increase the number of people that voluntarily go for the test is still because there is stigmatization, discrimination of certain communities. And people are afraid to go to the test, afraid to be positive and to be excluded from their family, to be excluded from the society. We have to fight. We have to fight for social justice and human rights, which are very important for peace as well. Vaccine failure. Vaccine failure, just a few words to say why it has been so much failure. Many obstacles, including our lack of knowledge of the response, protective response that the vaccine should induce to have a protection. We have to understand better today what are the mechanisms of protection, what are the alterations that this virus or component of this virus are capable to alter rapidly, the key players of our own defense against infection. We have to understand better the latency also, and we have to consider a vaccine that should be able to block the transmission of the virus from one infected cell to another infected cell. What will be the solution for tomorrow? It will be new innovative concept based on a better scientific knowledge and very early advance, resulting in pathogenic signal that are able to alter the protective immunity, in particular in infected site. Of course, it has been this result of the TIDE trial at the end of last year, showing a modest effect of protection, only 30% of protection, but for the first time we had a vaccine in our hand showing some protection. 30% of protection is not enough. At least a vaccine should be efficient by 50%. However, this vaccine trial is raising new questions, important questions that we have to answer. We have to first know whether the strategy that was used for this vaccine trial, what we call the prime boost strategy, to prime by a first vaccine candidate and boost by a second vaccine candidate, is a good strategy. And certainly we don't have the best vaccine yet, but we have to work on that strategy to try to improve the immunogen for tomorrow. And we shall, through the vaccinees, lucky vaccinees that are protected in this TIDE trial, we might be able to understand the mechanism of protection that the vaccine was able to induce. We already have some information that indicating that it's not the classical protective immune response that those vaccinees have elicited after vaccination. So we certainly will learn tomorrow from studies on vaccinees, and we will be able to develop new vaccine strategy. We will learn also from other models of protection. Other model of protection that protected vaccinees, like for example those very small proportion of exposed non-infected individuals that are, for example, partners of HIV positive individuals. They have sexual relationship with their partners without any prevention and remain HIV negative. Why? We already have data indicating that genetic factors may be important, that some response may be important, but we shall continue to work on those individuals. We have also nice model of protection of the evolution of the infection against AIDS. Not protection against the infection itself, but protection about disease, against disease protection. And personally, if you ask me the question, I believe more in vaccines that will be able to protect against the evolution of the infection to the disease than a total protection against the infection itself. And for that, we have nice models. The first model that we have is this small group of patients, less than 0.3% of HIV-infected individuals that are infected since more than 10 years, some of them 15 years. They are seropositive, they have undetectable viral load, they naturally control their infection without any antiretroviral treatment. It will be wonderful if we can reverse the proportion and by a vaccine to transform everyone who is infected by HIV as an elite controller. And we are learning more and more regarding these elite controllers, the kind of response that they have. We know that the genetics of the host is important. We know that one proportion of this elite controller have a very efficient immune response against the infection, capable to eliminate the infected cells. We have another group of elite controllers for which we don't know the mechanism yet. And lastly, we have another model which is very complementary in my mind of the elite controller, because the African monkey in Africa that carry a virus very similar to the human virus HIV, they do not control the virus itself, but they control abnormal activation signal that is one determinant of the evolution of the disease. So we have two complementary models. One is to understand better the mechanism of control of the replication of the virus. The other is to understand better the mechanism of control of abnormal activation signal. And what will be the vaccine for tomorrow? We have to keep in mind that we will probably never have a vaccine that will entirely block the infection itself. And in the case of an infection like HIV, if you still have a remaining replication of the virus, that means that you will still have components of the virus at low level that might be capable to induce abnormal activation. That means that we might need to have a combined approach, blocking both with the vaccine, the infection, and blocking the immune activation signal. That means to have a combined vaccine, a combined immunogen to block the infection and the evolution of the disease. Keep in mind that HIV/AIDS is among one of the Millennium Development Goals. This goal is saying that we have to halt and begin to reverse the spread of HIV/AIDS, but we have to ensure at the same time that the response to HIV/AIDS is further integrated within and benefits the health system as a whole. This objective should be reached in 2015. We have a wonderful opportunity indeed in our hand today to change the course of history in global health equity. The fight against HIV/AIDS from the beginning up to now has been a unique impulse of solidarity for equity. Since the very beginning, and we are ready to continue today, and we will need you, the young generation in the room, to continue the dialogue between communities, to raise all together our voice, our voice for equal access to treatment, equal access to care, equal access to prevention at universal level. We have to raise our voice for social and legal justice for all. We have to raise our voice for the end of stigma and discrimination based on serological status and gender or sexual orientation and so on. We have to raise our voice all together for equity for all, for tolerance. It's our responsibility. Of course, it's the responsibility of political leaders, but it's also our responsibility. And really, we need you. We need you to think about the responsibility that you have for the benefit of humankind in order to respect all the population in the world, which has the basis of peace. Thank you very much for your attention. And of course, as part of the dialogue, now I'm waiting for your question. Laurent is starting.
Dear Francoise, thank you very much for this fascinating overview. You pointed that stigma and discrimination as a key limiting factors all over the world to go ahead and tackle the epidemic. Don't you think that it's now time to really de-dramatize the epidemic? Let's say in international conference, HIV is still linked to AIDS. While in HPV and hepatitis conference, we don't think it has cirrhosis, for example. And could we say that now HIV is an infection in a chronic disease, a little bit like diabetes is, and consider it in a de-dramatized way?
On one hand, I entirely agree with you, Laurent, and you know that it's already the case. It's already the case, at least in rich countries, we are not speaking anymore about AIDS. We are speaking about people living with HIV, unharmed. So we are not speaking about AIDS anymore. However, we have to take into consideration the profile, the pattern in resource-limited countries still, where we have AIDS mortality because of the insufficient access to antiretroviral treatment. So I think we already started to de-dramatize AIDS, but in another hand, you have to be careful as well, because you can, as a result, we can have the situation that we are starting to see also in the rich country. The fact that in United States, but also it's the case for us in our country, in France, to see again an increase of HIV infection in some communities. The first community, I would say, like the beginning in HIV/AIDS, affected by the new cases of infection is homosexual. There is again an increase of HIV infection in homosexual population in United States, in Europe these days. And probably it's because of the fact that the message, we say, okay, this is wonderful, we have a treatment today. And of course, they know it's not a cure. They know it's not a cure for AIDS. It's not a cure at all. But they feel that anyway, if they get infected, they can be treated. So we have I mean, on one hand, I entirely agree. On the other hand, we just have to find the right balance, let's say. And of course, for me, it's not only a question of drama regarding HIV/AIDS. It's really a question of when you speak with people, they're afraid to go for the test. They're afraid because of the eyes of the others. Or if I go to the test, maybe my neighbor will think that even in France, it's still like that. I mean, they will think that I am homosexual. Or for women, they will think that I am a prostitute if they know that I go for the test. I mean, this is unacceptable. Really, we have to stop that. I mean, I very often ask, even a short anecdote. Last year I gave a talk at the American Club. So I got a question by, at the end of my talk, one American guy stand up and said, why are we focusing so much on this infection that affected these communities of homosexual and prostitute? I said, that's enough. That's enough. You have to keep in mind that 80% of people that are infected are maybe you here that is raising this question. Or if it's not you, it might be your children one day because of the behavior that you have. So, I mean, even today in our countries, in the rich country, we have this kind of statement regarding population unfortunately affected. And I asked the guy, would you have the same statement for people that are affected by hepatitis infection? He said, certainly not. I said, but the virus, the transmission is by the same mode. So why? Why is so much differences between your statement on hepatitis and HIV? It's not the same, he said. So, I mean, you can see that there is a real problem and we have to fight. Of course, we have this situation in our countries, in rich countries, but in some countries, like Eastern Europe, it's really a drama today. It's really a drama because the political leaders are not taking care at all about HIV. Because the epidemic started in IV drug users and MSM. And as a conclusion, the police, through information they get, found the MSM and IV drug users and they put them in jail, where they had to go through violence, criminalization in jail, and of course no care and treatment. Shall we accept this situation ourselves? At international level, certainly not. So it's why we have to raise our voice really very strongly to fight against this situation which is in opposite to the respect of the human rights, to the opposite of, let's say, life, the right for life for all. And the reason why the International AIDS Society will organize the conference in Vienna next July, because we say, okay, we have to raise our voice all together in a country which is close from Russia and countries around, to try to convince the political leaders there to take decision regarding infection and healthcare, let's say, in general, for all the population. And it's really the role of course, of the International AIDS Society to to be an advocate for all in the world. And as you know, it's what we did already for South Africa at the time that the President Mbeki was claiming everywhere that HIV was not the cause of AIDS and that the cause of AIDS was poverty. Of course, poverty is one component of the situation, but we all know that it's clearly scientifically based that this virus is the cause of it. That is why we raised our voice at the time by the Durban Declaration during the International AIDS Conference there. Of course, it was not 100% successful, but after a while, it turned out that the situation today has changed in South Africa. The government has changed as well, and the patients over there have started already to be on treatment and care. So I mean, it's important. I mean, we have to convince others. Of course, scientific evidence-based justifications, of course, but also, I mean, we have to make understand to everyone how much is important to respect the others everywhere in the world. This is really part of equity for all, and it's part for me of peace, and of course is the reason why I'm here, because I think the dialogue and education is really a very important component. Yes.
Hi, I have two questions. One is, can you explain why you came to Cambodia originally to do your research, and why you returned now to give this talk? And then the second question is, out of your presentation here today, which information is the most new, what has not been presented before?
The first part, I will maybe change your first question, because I did not come in Cambodia to make my research. I mean, I'm not interested in coming in a country to do my research. I'm coming in the country for the country to make their research, which is totally different. I'm not coming in the country here to collect samples to bring back in Paris. I'm not interested in that at all. I know some others can do that. That's not the game for me. If I'm coming here in a country like Cambodia, and Cambodia is not the only one, because I've been working first with Africa. As I said before, it's because I realized the situation in those countries, and I was personally convinced that research is part of the game for the development of those countries. It's part of the game for education, for capacity building, for the development, and also to provide locally scientific evidences that could convince the political leaders at the national level in the country to take decisions. So it's not for me to make to answer to your question. It was not for myself. It was for the country. And of course, I mean, some part of the work, some time has been done in real collaboration, and we publish together. But I mean, the application of the research should be really done here in Cambodia or in other countries that we are working with. So this is to answer to the first question. It's not really a personal choice for me, but really for the country. The second question, what was new in my presentation today? Certainly not to too much for you that are already aware about HIV/AIDS research. That was not a scientific presentation, I must say. It was, I'm used to make scientific updates or to work or to present more in detail some of the aspects of should have maybe presented more data on elite controllers. We have very nice data on elite controllers, for example, these days, showing that about the genetic factors responsible for the natural control of infection, data regarding innate immunity and the role of innate immunity in natural control of infection. But I don't think that was really what Uwe was expecting for me. It's different to make a very technical presentation. It's not really helping the dialogue between the students and the scientists. So I will be glad in another visit to make a more scientific presentation about the last development in research. I could have also give you some new data on the African monkey model regarding also the role of interferon alpha and the role of this cytokine and the balance between the level of this cytokine in the control of immune activation signal. I mean, there is plenty of new data, but that was not the aim of this talk today. Now, if you want to speak after with me, I will be glad to do so.
From National Institute of Public Health. Thank you, Professor, for your excellent presentation. I know you are a scientist, but I invite you to think a bit out of the box into the system perspective. As you shown in the last slides about the MDG goal or the benefit of the system. So we all know that there are opportunities in every problem. And HIV/AIDS is a big problem. And then, yet we have not seen much of the benefit or opportunities. You talk about science. Yes, we benefit a lot as far as science is concerned. But as far as system, disease prevention and control system is concerned, we have no strong evidence that HIV/AIDS have contributed much to that. So
you will have it.
Yeah,
you will have it because
I would invite you to ask or to talk a bit on from the global perspective, and the question whether we have benefited enough as a system from HIV.
It's a question that very often is mentioned, opposing, let's say, all what have been done in HIV/AIDS and forgetting, let's say, other human pathology affecting the poorest countries. This is ridiculous, really, in my opinion. This is ridiculous to oppose both. Because, of course, it's too early to see the benefit of what has been done on HIV/AIDS, on other improvement regarding health system in those countries. It's too early. It just takes time. But you know that it's already one of the aim of the Global Fund to make such evaluation. And they have preliminary data indicating already that we are on the right track. Okay. It's not enough data yet. I agree with you. And certainly we will learn from the evaluation, which is ongoing, on how to adapt and to improve what has been done up to now in the field of HIV/AIDS, but not only HIV/AIDS, because the Global Fund is also tuberculosis and malaria. I mean, what has been done by the Global Fund that is improving the global health system in the country, the evaluation will give the answer. I don't have the answer today myself, but I'm sure that we will have the answer, and we have already some indicators that are showing that we are on the right track. Some indicators might not be as good as we wanted, and we will have to make changes, that's all. But I really think it is ridiculous to oppose both. Any other question? Yeah.
Thank you for your presentation and your presence here. I'm today from Pasteur Institute of Cambodia. I would like to ask one question regarding to the AIDS vaccine trial that have been tested in Thailand. And for your expectation that you see when you get start for the next vaccine trial with because your result in Thailand is just only 31%. So when you get to start for the next trial, I mean, you think that you get started soon or for a long time?
First of all, I want to clarify it's not my results. This trial has been done in Thailand by the Ministry of Health of Thailand in collaboration with the US Army and also pharmaceutical companies, Sanofi, Aventis, Pasteur, and Vaccination. So it's not my work at all. I mean, this vaccine trial, as you summarize, is not efficient enough, but I know that the investigators of the vaccine trial, what was done in Thailand, are already, first of all, are making a lot of studies right now on the volunteers of this vaccine trial in Thailand that has been protected, and on those volunteers that have not been protected, to try to understand better the immune response that are protective or not, and also to try to understand better observations that has been made during the trial regarding in the vaccinees that have not been protected. When you compare to control, they have exactly the same viral load. They are both infected, the control and the volunteers, and according for measurement of efficacy of vaccine itself. So there is several questions that are raised by the vaccine trial. Some of those questions will be approached by studies on the volunteers enrolled in that vaccine trials. And I know that the investigators are already thinking about making another trials in the same region. Thailand, of course, will participate to the future vaccine trial. with a new protocol and new immunogens, but using the same prime boost approach, priming the response with ALVAC, with a vector, that's a viral vector containing HIV genes, and boosting with a viral protein, namely the glycoprotein of the virus HIV. But in the Thai trial up to now, it was the monomeric form of the envelope, and they are planning to do it with the trimeric form of the envelope. That need to be organized. I mean, you have seen on my slide probably that it was a trial enrolling 16,000 volunteers, 1,000 volunteers in each arm. You know that this trial started in 2003. We got the results in 2009. That means 6 years to get the result of such efficacy trial. So we have to continue, of course, to make new vaccine trials, probably according to the prime boost strategy. And I can tell you, we have already other vaccine trials that are going on, both in Europe and in the United States, based on the prime boost approach, for which we will have to wait for months or years to have the data. Meanwhile, and that was certainly the conclusion of the vaccine trial for which we got the data in 2007, called STEP trial. This trial was very deceptive, not only showing that the vaccine used in that trial, for which we got the results in 2007, was not efficient, but also we found out that some of the volunteers that were vaccinated had a facilitation of the infection by the vaccine itself. So we have to be careful. At that time, the trial stopped, and the scientists, I mean, was an international meeting, and the conclusion of the meeting was to say, clearly, we have to rethink, to have new concept, and to go back to basic science. To go back to basic science, that was the conclusion of the international summit on HIV AIDS vaccine. And it is what we are doing these days, to rebalance, let's say, vaccine trials and basic science together. This is the agenda. It is an alliance that has been created already several years ago, named the Global HIV Vaccine Enterprise, where you have representatives of the main institution, agency involved in HIV vaccine research in the world. And we have regular meeting of the Global HIV Vaccine Enterprise, and we define a new agenda for HIV vaccine research. You will probably hear about it during the year 2010, because the Scientific Advisory Board of the agency have worked very hard, and we define a new strategy for HIV vaccine research at international level. So, vaccine trials are still ongoing. En ce qui concerne, Sorry for answering French. So I will answer maybe in both languages now that I start. I will first answer in English. The prevention of mother-to-child transmission. There is, let's say, in rich country, no more new data because we don't have any more mother-to-child transmission in rich country, as you know. All the women are unharmed when they are HIV positive in Europe and United States, and as a result, we have less than 0.1% of mother-to-child transmission in the rich country today because the women are unharmed. The last data now regarding prevention of mother-to-child transmission of HIV-1 are based on studies that has been conducted to find out what is the best strategy to prevent the transmission by breastfeeding. And it has clearly been shown, and there is already WHO guidelines in consequences to the research performed, indicating clearly that if you use antiretroviral treatment in the child, but also in the mother, when the mother is breastfeeding, then you can prevent the transmission of the virus to the child by antiretroviral treatment. So I will say again that the new data are regarding the prevention by antiretroviral treatment of mother-to-child transmission by breastfeeding. Very shortly in French, les derniers résultats de la prévention de la transmission mère-enfant concernent la prévention de la transmission mère-enfant par l'allaitement à l'aide d'antirétroviraux, où on sait maintenant que si la maman qui allaite est sous antirétroviraux avec, dans les premiers jours de naissance, un traitement également par des antirétroviraux de l'enfant, on peut prévenir la transmission du virus à l'enfant durant la période de l'allaitement sans pour autant stopper l'allaitement de la maman. So it's mostly, I mean, the most important issue of the research on PMTCT is certainly the breastfeeding issues. I mean, for the rest, the prevention of mother-to-child transmission at time of delivery, we already know what to do. We have antiretroviral treatments that work at delivery or even during pregnancy for preventing mother-to-child transmission. So, I mean, for us, the prevention of mother transmission, it's not a question anymore of research. It's a question of implementation. Implementation of the advances of the research. Okay. And this is the main issue for Cambodia, especially for Cambodia, because, of course, everything went quite well regarding the prevention, the diminution at least of the incidence of infection in adults and the access to antiretroviral treatment in adults. But as you know, as a representative of the Ministry of Health, it has been some delay regarding the prevention of mother-to-child transmission by antiretroviral treatment here in Cambodia. And I think it's not a question of research for me, it's a question of implementation, organization of the prevention of mother-to-child transmission by antiretroviral treatment here in your country. And early diagnosis, I will say. You have to improve also early diagnosis of infants here and early treatment in infected infants when they are infected.
Madame Barre-Sinoussi, à tout numéro, ça à propos de problème du dépistage, du problème de maternisation, du dépistage, et c'est là où les choses ont changé. Et nous, on a 90% des femmes qui sont HIV positives ne le savent pas parce que le HIV c'est
I totally agree with you. It's the reason why at the end I wanted to stress on that point how much it's important to early diagnose the HIV-infected infants and to take care of those infants and treat them. And to have also information on the response of HIV-infected infants on treatment, their response to the treatment. But we have to work also on both, let's say, because we also have to reduce the number of cases of transmission from mother to child as well. Comments?
From University of Health Science. I've got a question for you. During your speech, you said that the circumcision can reduce the rate of HIV infection up to 50%. And I want to know the mechanism of this reduction of the HIV infection rate. And is it for only is the reduction rate for only the men or women or both of them? Thank you.
Yeah, it has been, I mean, there has been study showing that we can, the circumcision process is, let's say, eliminating the risk of target cells, which are usually present, so you diminish the risk of transmission because you have less target cells during sexual intercourse after circumcision compared to uncircumcised individuals. So it's a question of proportion of target cells that are present or not. So it's why you have partial efficiency. Regarding the reduction of the risk, of course, it's a reduction of risk of transmission from female to male or from male to male. Because the circumcised are male. So, of course, still we have certainly to have more data at large scale. There is ongoing study right now in South Africa to evaluate the impact of circumcision in the real world, let's say. So there is a very, very large study, and of course it will take care to have the response because it's a study using circumcision at large scale in a whole population in South Africa. So, first answer, biological explanation explained by the proportion of target cells, which is lower when you are circumcised. And second part is mostly regarding proportion reduction of infection from female to male if the male is circumcised. Other question?
Je pense que vous êtes un peu fatigué. Si avant d'arriver à la question, je vous raconte une petite histoire. J'ai un ami, il a niqué avec une prostituée et il ne savait pas son préservatif a percé jusqu'à la fin et il sait et puis il avait peur. Et donc il est allé chez un médecin qui est spécialiste du traitement HIV et puis son message lui a donné des médicaments pour prendre pendant 30 jours. Est-ce que ce médicament est efficace ou pas? Si oui, il faut prendre avant combien de temps après l'accident?
Les prendre le plus vite possible, as fast as possible after exposure to HIV infection. It should be within the next hours after exposure to the virus or to the infection. But the drug, of course, it's very efficient in antiretroviral treatment. The data on post-exposure are not 100% positive, but it really depends on the timing after exposure to the virus, as fast as possible.
Thank you very much indeed, Professor Barre-Sinoussi, for that Professor Vincent, Director of the Pasteur Institute of Cambodia, please come up to the stage.